us for suggesting to talk about contraception and drama, but it needs to be done. And creating groups of mother-in-laws where they can talk about what is the importance of health of their daughter-in-law, and birth spacing will automatically come. So times are changing, and we have to change according to the times and create a new outlook for people so that they're interested in what we are talking about. Because what we talk about now, women are not interested, and that is why I thought, what is it that can be different, which people will really look into and then talk about it. And the second thing is that if somebody actually initiates a method of contraception and comes back to the consultation, we have to give them time and attention and resolve the problem. Because if we don't resolve the problem, they are going to leave the method. Many women come to us with removal of PGIOD just because that they had a problem and they did not come to us, they went to somebody else and they said, oh my God, what have you done with yourself? Get it. So we need to be fixed. I'm not going to go into the details of the contraceptive methods, but I just want to share something for the crowd who will be interested in it. Because whenever we are giving contraceptive pills, at the end of the day, everybody wants to prescribe something. So this is just to share with you that other contraceptive options are available in Pakistan, and if you want to use these options, they are there. The second thing I want to say is that injectable contraception is something which we haven't actually explored enough as much as we should. So injectable contraceptive or progesterone only methods and combined methods are also available. And this Sayana press which is coming, which is a self-injectable subcutaneous injection, is also going to be available in the market very soon, and it is already there, but not commercially. So we need to be thinking of these options for our patients. Emergency contraception, which is one of the few, how many of you are prescribing contraception for contraception? One hand. Two. Okay. So two hands out, three. So three hands and I'm the fourth one. So 4 hands out of the crowd means that the message that is being delivered here is not enough. We need to recreate it again and again, and this is an important tool which needs to be utilized. Nothing much to it. So it's just a vaginal ovule, to which the woman needs to know that she has to have the ovule in time, and it has to be inserted in the vagina about 10 minutes before intended sexual intercourse. It is non-hormonal, it is safe, it is effective, and it will dissolve. So no side effects, no burden on the woman, so no fear of complications for our particular set of women who are vulnerable. So basically what it is doing is that it is destroying the cell membrane of the spermatal gland. So that actually is the mode of action, and it is also good antiseptic. So it will not pass into the uterine cavity, it will not be absorbed in the body, it will not go into the blood or breast milk or anything else, and no probability of pregnancy at all. So this is a method which should be used and which should be propagated. Now, what are the guidelines we use? As I said, 10 minutes before intercourse, and it will last, the effect will last about 4 hours. So that sounds pretty much okay. And every time they have sex again, they should use the same method. The only precaution is that the soap should not be used immediately before or after intercourse. That's about it. So this is something which is acceptable, which is usable, but which as healthcare providers we are not talking about enough. And that is why we need to be talking about it. The only thing which can happen with it is allergy, or if there are lesions in the vagina, or if the woman has got no vaginitis, then it might not be a good choice. Or if the woman is using intravaginal creams for treatment of vaginal infections, then it is not a good choice, but otherwise we are okay with it. So it is safe, it is tolerable, except sometimes local irritability. Not a problem, it is safe for women who are lactating, so it is something which should be recommended. I am not saying that this is going to take over every other thing. That is not the message for today. The message is that if women are not listening to you for other methods of contraception, maybe this needs to be talked about, and maybe you will find women who will be willing to use it more efficiently than other methods. So something is better than nothing, and I think that we need to introduce this as an option for women. So when a woman visits a doctor, I think it is very important that the doctor should bring up the topic and discuss with the women what is it that is available for them which they can use for contraception. And the next thing actually brings me to my last slide. Patient always asks what is best for me. And as healthcare providers, it is our responsibility to guide the couple in the right direction. But remember, this is the world of informed consent, and this is the world of rights-based approach. So the ultimate decision of the type of contraception that they want to use rests with the couple. Thank you very much.
Thank you, Professor Rina, for a very detailed talk on contraception, so very thought-provoking, but giving us alarming results. Why we are still having stagnant contraceptive prevalence rate? Alarming वो भी है, जिसको भी देख के लग रहा है कि शायद कोई बहुत ही alert situation है, ये जो सारा ड्रोन चल रहा है, इससे भी कुछ situation को वो ऐसा कर दिया है. Anyways, solutions are there. It is always the person behind the solution. We gynecologists still are, and we will be responsible for implementation of these methods. I think Dr. Rubina's suggestions for out-of-the-box thinking are there to be, definitely there are many repercussions for those things, but still we can think about that and we can make use of them. Thank you very much. Now moving on to the next topic, and Professor Dr. Ashit Jahan is going to talk about the role of progesterone in male infertility. A renowned name in the field of obstetrics. आपका टॉपिक चेंज हो गया है. रुबीना ने इतनी आउट ऑफ द बॉक्स चीजें बताई कि आपका टॉपिक ही चेंज हो गया.
कहते हैं ना भूखा बड़ेरा अच्छा लगता है. मैंने पूछा है खाना कब मिलेगा, कहने ने पीछे दिए जला दिए हैं, इसलिए आपको खाना जल्दी मिलेगा. I was asked to talk about the role of progesterone. आजकल प्रोजेस्टेरोन इज इन और तकरीबन हर बीमारी का इलाज प्रोजेस्टेरोन है, बट पर्टिकुलरली वो कह रहे हैं प्रोजेस्टेरोन के बारे में the obstetricians have learned more than before, and the scope of progesterone has expanded in the recent times. BM Biotech का शुक्रिया कि ये जस्ट नवी प्रोजेस्टेरोन लेके आए हैं, तो आज हमें यहाँ खड़े होने का मौका मिला है. Recurrent miscarriage एक dilemma है which everyone has to face in clinical practice. And the most difficult part of dealing with the patient suffering from recurrent miscarriage is to answer our questions. The first question that you have to face is why this miscarriage has happened. What is my future? And in Pakistan they ask you what is Atra. I am suffering from male Atra, I am suffering from female Atra, I am suffering from combined Atra. So these are the 3 questions which you have to answer to all of them. तो आप सबसे अच्छा काम ये करते हैं कि जब कोई पेशेंट 3-4 डॉक्टरों को दिखा के आता है तो आप पहला कागज देख के दांत चढ़ाते हैं, फिर दूसरे पे आंखें घुमाते हैं, तीसरे पे कहते हैं कहाँ फिरती रही हो तुम्हें, मैं इतनी देर से क्यों मिली। तो देखना कैसा चमत्कार होगा और देखना मैं जो करूँगी वो कैसे होगा। और जब आपके पास इलाज चलता है कुछ देर और उसके कुछ अर्से बाद मिसकैरेज दोबारा हो जाता है, तो देन यू डू नॉट फाइंड द वे टू गो आउट, तो मैंने जाना किधर है और कैसे हुआ। उस सिचुएशन में इफ आई आस्क यू क्वेश्चन हु हैज बीन जनरेटिंग मिथ्स एंड हु इज जनरेटिंग मिथ्स टुडे, शुरू से हम सोचते हैं दाइयां मिथ जनरेट करती हैं, हकीम करते हैं, डॉक्टर नहीं करते। बट जब इस सिचुएशन में आते हैं ना, जब आपके सामने आपके ट्रीटमेंट के बावजूद द पेशेंट गोज इनटू एन एम्ब्रियोनिक प्रेगनेंसी और इट गोज इनटू मिसकैरेज, तो आपको भागने का रास्ता नहीं मिलता। एंड देन यू आस्क सर्टन, यू क्रिएट अ सिचुएशन कि आप ब्लेम पेशेंट पे डाल दें, अपने आप से बचा लें, एंड दैट इज द टाइम व्हेन यू जनरेट मिथ्स। हमारे यहाँ सबसे बड़ा मिथ है सीनियर चलने से प्रेगनेंसी ज़ाया हो जाती है, और ये डॉक्टर का एस्केप डोर है कि जो ही किसी ने कहा कि मेरे ट्रीटमेंट में मिसकैरेज होगी, आपने तुम सीढ़ियाँ तो नहीं चढ़ दी थी, एंड शी सेज तो देन यू फाइंड एन एस्केप ऑफ We live in a country where cousin marriage is very common, and आज आपको एक बात समझनी है how to handle this situation when a patient comes to you and asks you why did I miscarry। पहली बात ये है कि मिसकैरेज की आज तक पूरी दुनिया में सिर्फ 7 वजूहात का पता चला। We have little knowledge about recurrent miscarriage, particularly at genetic basis why women miscarry. We assume, we calculate, we describe, we give reasons, but only these are the 7 definable causes where science has developed certain treatments which can be offered to the patient suffering from recurrent pregnancy loss. 1 is genetic, 2 is anatomical factor, 3 endocrine, 4 immune factor, 5 is thrombophobia, 6 infective, 7 environment. These are the 7 areas which you must remember if you want to answer a question of the patient. Majority of the miscarriages associated with cousin marriage are not treatable in the current state of knowledge. Maternal age is important, and paternal semen, if you have the normal semen percentage less than 4, that has some role to play in miscarriage. But what hope can you give to these individuals when you say the knowledge is limited? We don't know how to treat recurrent miscarriage. We can't help you. But what hope can you give to your patient is that even after losing 3 consecutive pregnancies, she still has a chance of 70% to have a normal pregnancy subsequently, with or without treatment, whether we find a cause or we don't find it. There are 2 things in this slide. 1, when a patient presents to you with a pregnancy loss, you need to take the full detail of happenings surrounding that miscarriage. If the pattern of miscarriage is same every time, that indicates that there is a permanent cause and the probability of miscarriage happening next time is still there. And if you have a patient who has 3 miscarriages, every time the pattern was different, that means probably different causes are operating, and the probability of this happening next time is less than when you have the same pattern. Number 2, whenever if somebody comes to you with a recurrent pregnancy loss, try to ask them if it was a mid-trimester, was there any diagnosis relating to that miscarriage, any disorder of the baby was named in the previous pregnancy, so that we can offer prevention this time in terms of medication or at least antenatal diagnosis. अगर आपके पास डायग्नोसिस हो तो आप अगला एंटीनेटल डायग्नोसिस करके उसको बता सकते हैं कि आपके बच्चे में वो प्रॉब्लम है या वो प्रॉब्लम नहीं है। If somebody comes to you and tells you that मेरी abnormality तलाश करें and let me know what I am suffering from, you can't offer a series of tests on her and find a cause, whatever cause it was. The clue in the past history is what was the pattern of the miscarriage, and number two, if any pediatrician, if somebody loses pregnancy in the mid-trimester or later half of the pregnancy, and if you have a diagnosis related to that pregnancy, you can help them in the antenatal diagnosis, and obviously medication pregnancy is important. Next question. What is the value of doing karyotyping in patients with recurrent miscarriage? The RCOG guidelines are displayed here that if you want to do karyotyping in case of recurrent miscarriage, it should be done on conceptus rather than parents. And if conceptus report is insufficient or is not doable, then parental karyotyping is indicated. You must remember in Pakistan or worldwide what is the explanation in genetic counseling. In genetic counseling, we tell them the probability of that thing happening again, and if it is a recurrent or a permanent kind of disorder, we tell them do an antenatal testing and then get pregnancy terminated. Or we tell them go for donor insemination or donor egg donation or adoption. In Pakistan, rather worldwide, very few genetic disorders can be helped. So we are going to offer them adoption, we are going to offer them donor. In Pakistan, we can suggest them second marriage, but I suggest you don't suggest it because the first marriage के भाई आपको आकर सख्ती से पेश करें. So do not whisper in their ears, go and get married again. इशारन तब बताया करें. टीवी देखते हैं आप, टीवी पे वो कहते हैं आप इशारे से समझे मैं क्या कहना चाहता हूँ. पूरा पाकिस्तान इशारों से समझाता है, टीवी बात नहीं करता. So in case of genetic counseling, you have to understand that we cannot help a lot of these patients who are suffering from genetic disorder. They have options. Donor is not allowed in Pakistan. इसकी 3 साल सजा है किसी के स्पर्म मिसयूज करने की और 10 लाख रुपया जुर्माना है डॉक्टर को भी और पेशेंट को. नंबर 2, नंबर राइट पे देखते जाइएगा, मैंने 7 पूरे करने हैं. पहला जेनेटिक्स था, दूसरा एंडोमेट्रियल रिसेप्टिविटी है, दूसरा बहुत लंबा है, अगले छोटे छोटे. We talk about endometrial receptivity. Once the pregnancy happens, the first thing it needs is endometrium for implantation. Or endometrium and implantation is a complicated process which involves adequate preparation of the endometrium. Estrogen, progesterone are essential for appropriate implantation, and corpus luteum plays the most important role. Implantation remains an unsolved problem in reproductive medicine and a major cause of infertility and otherwise. जिनमें unexplained infertility कहते हैं आप, या जिनमें chemical pregnancy बार-बार खाया होती है, उनमें implantation failure has a role. And 2/3 of the implantation of failures are due to inadequate uterine receptivity, while 1/3 is because of the embryo. You know, menstrual cycle has 2 windows. One is called episode window, which is used for ovulation reduction. That falls somewhere between day 2 and day 5 of the menstrual cycle, and second is implantation window. Implantation window is actually 4 to 5 days after the ovulation, and it is at around 20 to 24 days of menstrual cycle. What do we mean by implantation window? A specific site in the endometrium is prepared to offer the implantation to the pregnancy, and that is very important. The human endometrium is primed for blastocyst attachment and has acquired an accurate morphological and functional state during this period. That is, a specific marker of uterine receptivity called pinopode is detectable under electron microscopic during this period. यूट्रस की एंडोमेट्रियम में एक स्पेसिफिक साइट के ऊपर ऐसी एपिथेलियल चेंजेस आती हैं जो बेड के तौर पे पेश होती हैं, एंड दे ऑफर इम्प्लांटेशन टू द एम्ब्रियो when it falls into the uterine cavity. Pinopode is defined as apical membrane of epithelial cell lining the uterine cavity, lose their microvilli and develop large and smooth membranous projections. These projections were named pinopodes. इनकी तस्वीर जो है ये इस तरह से इलेक्ट्रॉन माइक्रोस्कोप पे नजर आती है, एक स्पेसिफिक साइट है जो रिसेप्टर्स ऑप्शन प्रेजेंट करता है टू बिकमिंग एम्ब्रियो और उसको लॉक कर लेता है। जिनके पिनोकोड्स डेवलप नहीं होते, दे हैव पुअर एंडोमेट्रियल रिसेप्टिविटी एंड दे लूज प्रेगनेंसी एट द अर्लियर टाइम। एक दफा ऊपर जाता है या जिनमें कार्पस ल्यूटियम हैज द मेजर रोल in promoting the implantation and preparing the endometrium for implantation. And corpus luteum produces progesterone. So progesterone is one of the vital elements in the growth of pregnancy at the earlier times. इस स्लाइड में आपके लिए एक मैसेज है जिसको गौर से सुनिएगा। अगर आपके पास एक पेशेंट आती है जिसको recurrent miscarriage है earliest in the pregnancy, how would you treat her? Her treatment begins with better ovulation induction because poor follicles make poor corpus luteum. You need to, जब भी आपने recurrent miscarriage या miscarriage या early pregnancy loss का treatment शुरू करना है, you need to do a lot of tests before they embark at pregnancy, so these 7 causes are addressed before they embark at the next pregnancy. But at the same time, even if they are conceiving spontaneously, you need to make sure the quality of follicle is enhanced with your treatment. Better the follicle, better will be the corpus luteum. Hence, ovulation induction of some kind should be the part of treatment of those patients who are suffering from recurrent miscarriage, particularly because of corpus luteum failure. What are the investigations which you do for corpus luteum failure? You check the serum progesterone for day 21. If somebody has a progesterone level of 10 nanograms per milliliter on 2 consecutive cycles, they are in the need of progesterone supplementation and they are suffering from corpus luteum deficiency. What treatment can be offered for the corpus luteum deficiency? हमें बेसिकली जो फर्स्ट सेगमेंट है एंडोमेट्रियल रिसेप्टिविटी इनहांस करने के लिए वी कैन यूज HCG injections. What do the HCG injections do in these patients? They actually make the corpus luteum to produce more progesterone, and that is the natural progesterone coming from the body, and that cannot be replaced from the supplements. But progesterone can be supplemented in the shape of micronized progesterone. Progesterone is available in oral, vaginal and parental routes, and the treatment is generally, it says that the progesterone supplementation should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy, that is the threatened miscarriage, 409 milligrams, micronized vaginal progesterone twice daily till 16 weeks of gestation. So those who are undergoing IVF, there are different policies for supplementing luteal phase. One, they give them till the pregnancy test is positive. Others give them till the heartbeat appears, and others give till 16 weeks of gestation. And those who are having mid-trimester miscarriages, progesterone is now being prescribed for a longer duration. उसकी बात हम करेंगे. Number 2 का दूसरा हिस्सा, that is uterus as a host. One is endometrial receptivity, which I have covered. The next is uterus as a host. Uterus can have the congenital malformations. It can be malformed because of some kind of drug exposure while the individual was in utero. Diethyl stilbestrol was used in the past, now not used that much. So that's not a big issue. But acquired abnormalities, Asherman syndrome, uterine fibroids, and endometrial polyps can be reason for uterine abnormalities. आज आप में ऑडियंस में से बहुत सारे लोगों के लिए अगली चंद स्लाइडें नहीं होंगी, इसलिए जरा गौर से सुनिएगा। Uterus has 2 components. One is the body of the uterus and second is the cervix. Uterus, the body of the uterus is called capacitance structure. Capacitance structure means ये एक यूनिक कंटेनर है। अगर आप ग्लास में पानी डालें और पानी ग्लास से ऊपर निकल जाए तो ऊपर से नीचे गिर जाता है। But balloon is something, when you inflate with the air, it keeps on enlarging till it goes to the maximum. Uterus has a character that it expands with the expanding content of the pregnancy. It has to stay in correspondence with the rise in the content of the uterus. If uterus fails to expand in proportion with the expanding content of the pregnancy, the intrauterine pressure rises and the membranes are slipped at the internal os and prostaglandins release and cervix opens and pregnancy is expelled. That is the topic I am going to cover in next few slides. You need to understand how it is important for the uterus to expand in all directions in proportion with the rising content of the uterus. Why women deliver early in case of triplet pregnancy? Because the content is rising at a very rapid speed and sometimes uterus can cooperate and coordinate with it and expand at the same pace at which the content is expanding. Otherwise, it lags behind and it leads to rise in the intrauterine pressure and the pregnancy is expelled. The second thing is the cervix. The content of the cervix is important. Uterus का content predominantly muscular है और cervix का predominantly fibrous. Mullerian system कैसे develop होता है, Warfian regress होता है. इसमें 3 stages हैं. Number 1, it elongates and canalizes. Number 2, they fuse with each other. These are the two tubes in the Mullerian system. And number 3, there is a resorption of the central line and the uterus is converted from 2 boxes into single box, triangular box. And if it does not happen completely, these are the abnormalities which are seen in the Mullerian system development and all the content of the pregnancy. There are 3 things which we are going to be looking at when we are studying the uterine structure. One is anatomical variation, 2 is logical variation, and 3rd is its vasculature, because we need to understand that the baby grows in the uterus as a parasite is completely dependent on the mother, on the maternal blood which contains the nutrients for the baby and they are transferred to the baby through placenta and baby gives away its waste products to the mother. So the whole game is through the uterine vasculature which actually takes the nutrients to the baby at the placental site where it is exchanged with the mother and the waste products come back. So it is not only the musculature of the uterus which should be improved during pregnancy or in accordance, its vasculature should expand and bring most of the blood so that the baby can achieve its nutrition at the same time. This is the kind of anatomical abnormality that we see in patients who have reproductive difficulties. This is the extreme one where one side is blocked and that has to be treated. But if you look at the microanatomy of the uterus, there are gap junctions which unite with each other. The innermost layer is circular, the middle is random, and outer is vertical, and it is clearly seen in this picture that the uterine musculature runs in 3 directions. The innermost is circular, middle is random, and the outer is vertical. And आज के दिन की ये स्लाइड सबसे इम्पोर्टेंट है. ये आपको क्या कह रही है? ये कह रही है कि यूट्राइन बॉडी में देखना है तो देखें what is the proportion of the smooth muscle and the fibrous tissue. Number 2, how they are homogenized. Homogenization of the smooth muscle all over the uterine body is very important to facilitate expansion of the uterus in all directions. It does not give a preferential expansion on one side or on the other side. Number 2, the cervical component is predominantly fibrous, less muscular. If you have more muscular tissue in the cervix, it will give away and cervical incompetence will lead to pregnancy, expulsion, and communication between the upper segment and the lower segment is important. And do they have a septum in between, which is the incompetent part. And therefore, from now onward, the number 2 which I am talking about, you need to understand how important it is the uniform distribution of this muscle and fibrous tissue in all parts, and homogenization is important. What are the functions of the uterus? Uterus is a host which keeps the baby in, it expands in proportion jahan tak iski requirement hai. Number 3, it provides nutrition to the baby, and number 4, it takes away the waste products from the baby. You know where the carbon dioxide of the baby goes? It goes to maternal lungs from where it is exhaled. And where will the urea from the baby will go? It will go into the maternal blood and will be excreted from the kidneys of the mother. Hence, these are the functions which we are expecting from the vasculature, and we need to see how we go about it. ये तस्वीर आपको क्या दिखाती है? गौर से देखिएगा. If you come on the extreme left side, this woman has a uterus which has adequate smooth muscle and fibrous tissue ratio, and it is uniformly expanding, hence the pressure on the cervix is minimum. If you look at the middle, one part is expanding, other is not expanding. That means the smooth muscle and fibrous tissue proportion across the uterus is not uniform, hence the pressure is on the cervix. And if you look at the third one, that is bicornuate and there is fibrous tissue in between, hence the expansion is preferential and it is giving pressure and it is not going in proportion with the content of the pregnancy, and the cervix will dilate in the mid trimester somewhere. Normal content means single pregnancy, more content means double pregnancy, triple pregnancy. So in case of normal pregnancy, you will have problem only when the uterus is not expanding in proportion with the singleton. But in triple pregnancy, it is very common to deliver at 32 weeks, 33 weeks in the triple pregnancy, because even in the normal distribution of the smooth muscle, this uterus may not be able to cooperate or expand at the same ratio at which it is required in that case. When we have the vasculature, you know, what we need to understand here, the women who have abnormal uteri, women who have abnormal uterine architecture, they are likely to have abnormal vasculature, and what we require from the spiral arteries to provide multiple branches to the endometrium, and then to go through the first wave of trophoblastic invasion and second wave of trophoblastic invasion. If you find, you know, what is the cause behind hypertension in these women is the abnormal architecture of the uterus, abnormal vasculature, abnormal first wave of trophoblastic invasion and abnormal second wave of trophoblastic invasion. These patients are more likely to develop hypertension as compared to the other patients. See, ये normal physiology है. I'm sure you all know कि first wave goes up to endometrium and second goes to myometrium. But if you have architecture like this, you are likely to have the less spiral arteries will be invaded, less the myometrium portion of endometrium will be invaded, and the lower picture will come for you. Upper is the normal. See, in the case of the lower picture, the endometrium is invaded and vessels are dilated, but the intramural parts are not dilated. Hence, this slide is second most important. If a woman you see who is having mid trimester miscarriage, placental abruption, premature rupture of membrane, malpresentation, intrauterine growth restriction, all of them should be looked at with the suspicion they might have a problem in the uterine architecture. Therefore, all these patients, these conditions are predisposed by the abnormalities, and if you go home today, you should be asking yourself, if I have to number the causes of recurrent pregnancy loss, उसमें सबसे ऊपर क्या चीज आएगी? जेनेटिक के बाद यूट्राइन आर्किटेक्चर की अहमियत को आज से समझना शुरू करें और उसके ऊपर फोकस करें. नेक्स्ट इज द, यू नो, द थिंग वी नाइनर नीचे की पढ़े, IUGR, अब्रप्शन, सारी चीजों का प्रॉब्लम, मैल प्रेजेंटेशन का इरेगुलर शेप ऑफ द यूट्राइन कैविटी, स्मॉल यूट्राइन and poor blood supply are the features in these patients which lead to poor outcome. If you have uterine abnormality, there are high chances of malpresentation, which leads to increased rate of stable section. इस फेज की ये आखिरी स्लाइड है, वो गौर से सुनिए. ये जो तस्वीर सामने डिस्प्ले हुई है, दिस इज बाइकॉर्नुएट यूट्रस. एक कार्बन फुली डेवलप्ड है, एक कार्बन लेस डेवलप्ड है. प्रेगनेंसी लेस डेवलप्ड कार्बन में जाकर सेटल होती है, प्लेसेंटा वहाँ लगता है और वो रिटेन प्लेसेंटा के शक्ल बनता है. IUGR होता है बिकॉज यू विल नॉट गेट एडिक्वेट ब्लड सप्लाई इन दैट कॉर्नर. प्लेसेंटल डेवलपमेंट इज पुअर, मैल प्रेजेंटेशन, IUGR, लो लाइकर, दीज आर द इश्यूज व्हिच यू सी इन दीस पेशेंट्स. लेकिन ये स्लाइड आज की सबसे इम्पोर्टेंट स्लाइड. If you have a uterus which has muscular tissue only in a very small area, rest of them is predominantly fibrous tissue, the only part which has adequate musculature will expand large and the remaining uterus will stay small. This is called sacculation. My request to you today out of this talk is that once you deliver a baby at cesarean, you do not remove the placenta and move your hand over the fundus of the uterus. You will see how many of your patients with reduced lighter malpresentation, IUGR, have preferential expansion of one part of the uterus and the rest uterus is small. Once you remove the placenta, the surprising point in these patients is that once you remove the placenta, the uterus assumes its shape as normal. It was never abnormal. At hysterosalpingogram, it is not bicarbonated. It does not have the septum in it. It just gets V-shaped during the process of expansion. And once the placenta comes out, it regains its shape. It is so deceptive that unless you put your hand on it before removing the placenta, you will find circulation, otherwise you will not be able to find it. Now, the hysterosalpingogram is useful in this case, and should we perform septoplasty or should we perform metroplasty? People who are experienced should attempt these cases. You should not train by yourself on metroplasty. You will do more harm than the benefit. You must get a training under supervision of somebody to go for metroplasty. Otherwise, the new concept about progesterone is that progesterone has a smooth muscle relaxant activity and it has a role in the expansion of the uterus. It supplements expansion if adequate progesterone therapy is given in those patients who have poor expansion of the uterus. Therefore, HCG or progesterone in people who are suffering from mid-trimester miscarriages, if you give them progesterone right up to 35 weeks of gestation, their expansion comes to a point and they are facilitated and pregnancies go on. I have a series of experience in giving progesterone up to 35 weeks in patients who have preferential expansion of one part or at hysterosalpingogram they show uterine abnormality and the outcome has been good. Cervical suture, should we apply cervical suture or not? Typically, if woman ruptures the membranes in the mid-trimester without having uterine contractions, will surely benefit from cervical suturing. If they expel with pain, they do not benefit from suture, and suture should not be applied to those patients. The abnormality, fibroids, you need to see that submucosal fibroid matters for the conception and its outcome. Poor endometrial receptivity and degeneration releases cytokines which may interfere with the conception. Intrauterine adhesion formation, Asherman syndrome has a problem with the endometrial receptivity because there is not enough endometrium left. If you do uterine sounding and give oral contraceptive pills for some time, putting in the copper for 3 months, many of them have endometrial generation and subsequently they can have a problem of these pregnancies. Number 3. टू फिनिश हो गया 3 आ गया सो थोड़ा सा टाइम लगेगा बाकी 2 मिनट लगेगा सर डायबिटीज the most important thing about recurrent miscarriage, what tests should you be doing? Number 1 was, will you do karyotyping? Number 2, will you do hysterosalpingogram on them? These are the 2 lessons which I have covered so far. Number 3 is GTT, glucose tolerance test. Never miss to do a glucose tolerance test on those who are having recurrent miscarriage, because the patients who are chronic diabetic, they are at a high risk of early pregnancy loss. Those who develop gestational diabetes, by that time the probability of anomaly goes away because the embryogenesis lasts between the onset of pregnancy till 10 weeks of gestation. And if there is diabetes, you know what correlates with the probability of congenital malformation most is the blood sugar control at the level of conception. Hence, those people who are looking for pregnancy and they are non-diabetic, their diabetes should be controlled before actually they embark at pregnancy and the outcome remains good. Polycystic ovarian disease, the normal incidence of miscarriage is 15%. In polycystic patients, it increases by 2 to 3%. Hence, the polycystic, you cannot cure the polycystic disease, but use of metformin and myoinositol help in these patients to reduce insulin resistance, and that helps in lowering the insulin level, and miscarriage can be brought down. Thyroid, Thyroid is तीसरा टेस्ट है, चौथा टेस्ट है thyroid. Whenever you are testing thyroid, you do free T4 and TSH, not the total T4. And I tell you very precisely that thyroid function must be brought well within the normal range from the lower margin and from the upper margin, well within the middle to have good results. Marginal, clinically silent thyroid has adverse effects on the pregnancy outcome. Therefore, diabetes mellitus and thyroid out of the endocrine disorders must be dealt with very seriously when you are looking at patients. Immunological factor. Pregnancy is a graft. 50% component comes from the mother herself and 50% comes from the husband, and that portion of the husband is treated as graft. Hence, under normal situation, the progesterone has immunological suppressive effect, and during normal pregnancy, the immune system is suppressed, so the baby is not rejected. Those who have immunological factors, their immune response does not go down during pregnancy, hence they actually reject the male component and miscarriage occurs. Therefore, there is a place of putting these patients on prednisolone low dose throughout pregnancy if they are miscarrying repeatedly. Then comes thrombophobia. There are two criteria कि किन का करना चाहिए, but anticardial antibodies अगर किसी की 12 weeks apart positive है तो they should be given heparin up to 35 weeks of gestation from the time of diagnosis. Then comes the infections. पूरा पाकिस्तान टॉर्च इन्फेक्शन का टेस्ट कराता है और जिसका पॉजिटिव आता है उसको एंटीवायरल प्रिस्क्राइब करते हैं. I am trying to convey this message to everyone across the country for years that in torch we do not test the virus, we test antibodies. And if antibodies are present, that means the woman is immunized against that virus. Hence, there is no place of giving antiviral to patients who are torch test positive. Torch test positive, torch can cause, one virus can cause miscarriage once, then the body is immunized, and from next pregnancy she is protected from that virus. Hence, we should not be doing for torch. There is only one torch virus where the vaccine is available, and that is rubella. Otherwise, we cannot even vaccinate them. Therefore, torch का टेस्ट कराना और सिर्फ फायदेमंद एक सूरत में है कि अगर वो रुबेला नेगेटिव आती है तो उसको रुबेला वैक्सीन करा दी जाए. उसके अलावा एंटीवायरल देना is totally useless. Then comes bacterial vaginosis. Bacterial vaginosis has been labeled as a cause of pregnancy miscarriage, and in the first trimester we treat them with clindamycin. Treatment actually prevents the late trimester miscarriages. There is literature support for the use of rifocin and metronidazole, which is flagell, from 20th to 24 weeks of gestation, which helps in reducing the infections. Then comes the number 7 is the last number, so I am approaching to the end of the lecture. जो सबसे important बात है environment में, you go home with this message that how progesterone can change the intrauterine and uterine environment. It has 3 functions. It is luteal phase deficiency treatment. So early pregnancy loss can be prevented with the extensive use of progesterone. It promotes uterine expansion in all those who fail to expand during pregnancy. And number 3, it improves endometrial receptivity. Hence, progesterone is useful in preventing pregnancy not only in the first trimester, in the second trimester, as well as in the third trimester. Environmental factors, RCOG says women with recurrent miscarriage should be advised to maintain their BMI between 19 and 25. Smoking cessation, limit alcohol, and limit caffeine to less than 200 milligrams per day. इसमें हमारी कौम के ऊपर जो चीज़ लागू होती है, caffeine consumption है, बाकी चीज़ें खुफिया हैं, वो बताती भी नहीं है क्या. Coming towards the end, I am trying to tell you is subclinical levels important है. जो थायराइड के बारे में आपको बात मैंने की है. I have a series of patients where actually we kept the free T4 right in the middle and we got reduction in the genital malformations. particularly related to the bone marrow condition. These are the tests which are written in the books and literature. They are not of any use, hence you should not, in the current state of knowledge, waste money on these tests. Conclusion: anatomical abnormality, progesterone or surgery, endocrine disorder में डायबिटीज को कंट्रोल करें, इम्यून के लिए स्टीरॉयड मिलते हैं, जेनेटिक के लिए हौसला दें, और थ्रोम्बोटिक के लिए क्लेक्सिन है, प्रोजेस्टेरोन सब के लिए है, और एनवायरमेंटल फैक्टर्स में आपने अपने मशवरे देने हैं. लास्ट स्लाइड सेज बेशक किसी के 3 प्रेगनेंसी लॉस हो जाए, 4 हो जाए, आप उनको डिसअपॉइंट न कीजिए. कुदरत सब पे कादिर है और उस जिसको बच्चा देना है उसको देना है. एंड आउट ऑफ ऑल मिसकैरेजेस ए नॉर्मल प्रेगनेंसी कैन कम अप. 3 प्रेगनेंसी होने के बाद भी प्रेगनेंसी होने का चांस 70% रहता है. इसलिए बी पॉजिटिव एंड बी पॉजिटिव फॉर पेशेंट्स. थैंक यू.
Thank you very much, Professor Rashid, for highlighting the role of micronized progesterone for the expansion of uterine musculature and playing positive role in cases of regular miscarriage. Professor Dr. Al-Zafar, former principal of Lahore General Hospital and renowned obstetrician and gynecologist. May I request you, sir, to please come and enlighten us with your few remarks for today's session.
Respected professors, foreign speaker, Mr. Aboubakr Elnashar, my mentor, I think he has left now, and other senior professors, Dr. Prof from the and lady of the show, Dr. Shana. She is doing all the master's program which the biotech range is. She is the main person. I will not take much of the time. I don't know whether lunch or tea has been served or not. I'll just take 5 minutes. I have not listened to the previous talks, but I'm sure which the biotech has introduced, this is really going to revolutionize our ops and gynae. I was listening to Professor Rashid Chaud's talk, and it was a very nice talk, and Chaud sir basically taught everything about ops. So let's clap for him. There's nothing more is left. I think the topics are very interesting. And Dr. Venus must have spoken about that post-coital or before, immediately before contraception. This is a new concept. There was a concept of post-coital contraception. This new concept, immediately before coital there is a contraception. So I think, but this is a food for thought that you know to hit the mind of gynecologists. He should introduce this as immediately before coitus. It's a new type of contraception, and the way Razak Saab and his team has worked day and night, the biotech has really come up to all the expectations, and they have all the ranges of injections, gonadotropins for IVF, and then progesterone also, and then micronized progesterone, and they are gradually increasing. Then for insulin mediators for PCO also, testosterone, they have that also. I wish him all the best for future, and I'm sorry I didn't listen to your talk, sir. And I hope you visit Pakistan more frequently, and we want to have more linkages with think you belong to Egypt, and we would like to have more linkages with your country. And I think the Islamic world has really gone up. We have been attending meetings in Dubai and Saudi Arabia, and Dr. Rubina Sohail had arranged a very effective meeting this year in February, and all Africa, all Middle East, and from Saudi Arabia and India, Pakistan was there, and it was a very useful meeting. And now I think the time is that the Islamic world is really coming up, and Royal Colleges and other colleges of Europe, they are looking for the rest of the world, and the colleges are coming out. There was a time when we used to go there. Now the time has come that they are coming to our countries, because money somehow has come to Middle East. Money of all of the world is in Middle East at the moment. Europe is totally dry. Canada is totally dry. US is about to dry. The steps which Trump is taking, if he doesn't take those steps, US will come up to the same situation. So I think this is the time we should pull up our socks and we should get together and we can do wonders. If there's a lot of money, we have to apply our mind for research, and we have to come up, with new technologies, with new medicines. Dr. Faria Farooq, yesterday, they have that robot, and she did a very nice movie, and I congratulate her also. And all these people are sitting there, everybody is an institution. Nusrat is sitting there, we have started Society of Gynecology also. And a request was asked also that maybe you should go into the sector of oncology also, because it's very, very important. There's a lot of gap in oncology, because whenever patient becomes unwell, the only option is we send it to Shaukat Khan. And recently Dr. Shariar and Dr. Nabila, they also started one hospital. But if pharmaceutical companies and they start working for oncology, we have started Society of Gynecology also. So there's a lot of gap it could also do. One thing I would like to mention, which I don't know if we have focused this or not. And I hope Dr. Yasmin Sardar is okay now. She had a fracture, she came to the wedding on wheelchair. I appreciate it. I don't know whether you have focused smog or not. And I don't know whether John has touched the topic or not. If you go on the literature and you do research in recurrent abortion, in IUGR, in malformation, there are a lot of papers coming out, and smog is the main cause of it. And yesterday also Lahore was number 1 in smog in the world. We have to fight it. This responsibility. Please go through the chapter. Go to smog, recurrent abortion, smog, malformations. You will find how this thing has evolved. And first, in 1950s, it used to happen in UK after Second World War. And then, they carried out some measures and got rid of smog. But being, doctors were the highest merit and have highest brain, highest intelligent quotient, I think we have to work. We should not expect others to do it. We have to start this work. And, with BM Biotech Health, we can have various seminars on smog, and let's talk about it and let's reduce it. At least if we go for awareness, you can reduce other problems. You mentioned that it is the uterus, and I second him. Barker says that whenever there is any metabolic delay, just follow this word. Barker's hypothesis. He says whenever there is any metabolic derangement during pregnancy, baby adapts itself to the changing environment, and things get incorporated into genes and mutation takes place. ECU is coming up, recurrent abortion is coming up, cancers are coming up, and with smog, and whatever it we are treating, we think that we have treated during pregnancy and baby was okay, but we have forgotten that we have created mutations in the genes, and those mutations will come up with different diseases. And smog will lead to mutations in the genes, and these mutations lead to different problems which baby will come across in the future. I will not take much of your time. I am extremely grateful to Biotech, to Razak sir, to Rehana, and to the main lady of the show, Professor. I hope she stays as young as she looks today forever, and she will never age. I saw her first time in 1996, and she is still the same. We have to find out what she eats and how she lives. So all the gynecologists today, I think, should interview her. That what are your eating habits and where you live and how you live. So I'm very grateful to Professor Sohail Lodi Saab, Professor Prof, Nazir Saab, Mehboob Saab. Some of them are my trainees, and I have become so old that my trainees are professors also. And now some of my trainees even are close to retirement also. Rubina Swim and myself, Great and Johan. We have always appeared for every promotion in the same year. And so, and still, it's a nice friendship, a nice teamwork. Sometimes, one goes there, and the other person comes there. But still is going on with her and Asmagul and Asma Yasin was my
इनका बड़ा बर्डन हो, मैं भी नहीं कर रहा, लेकिन वो क्लिपिंग वाला एक दो पीछे पड़ के ना पैसे इवेंट चल रहे हैं। अब सुबह मैं 6:15 आके सो रहा हूँ, सोते
Razak Saab and his team, they flourish more and they conduct and arrange more functions. This is time for networking, this is time to meet each other. Gynecologists are like one family, and today is the day. Please mark this thing. Surgeons are together, gynecologists are not together. They pull each other's leg. If gynecologists come on one platform, nobody can put an eye on you, and you will be the strongest in Pakistan. Please think over it, listen to them, come on one page, and you can defeat every other specialist. Thank you very much.
तो सिगरेट पीते थे, स्मोकिंग करते थे, कंज्यूम करते थे, उनसे बच के इधर लग गए।
थैंक यू वेरी मच प्रोफेसर अखिल तबर। बहुत सी खूबसूरत बातें हैं, और सबसे खूबसूरत बात कि गायनेकोलॉजिस्ट एक फैमिली है, और इस फैमिली को यूनाइटेड और हैप्पी रहना चाहिए। थैंक यू वेरी मच। सो अब यहाँ से जो मंजर नजर आ रहा है, शायद बैक पे तो पूरा लंच का अरेंजमेंट है, लेकिन आप लोगों को वो अरेंजमेंट नजर नहीं आ रहा। तो इसलिए नाउ वी आर मूविंग ऑन टू द लास्ट टॉपिक ऑफ टुडे, एंड दैट इज बाय प्रोफेसर Elnashar. May I please invite sir for talk on gonadotropins, role of gonadotropins in male infertility.
अच्छा सीपिया आ गया चौकस करना। ट्राइपॉड तो सही रखा करो, गंदे से ट्राइपॉड गल्ला तुहाडे को जिन्नियां मर्जी करा लो। मेरा उस्ताद बड़ा काबिल है अल्हम्दुलिल्लाह। मेरे उस्ताद नहीं वो मेरे उस्ताद नहीं ने भाई भावें टोक बैग लवा।
As we know, the causes of male infertility can be classified into pre-testicular, testicular, and post-testicular. And for the pre-testicular, it's called hybridization, where the FSH and LH and testosterone are low. We have what's called idiopathic male factor infertility, where we have abnormal semen and we don't know what's the cause. And we have what's called unexplained male factor infertility, where all the parameters of the semen are normal and the cause is unknown. This is the last cut-off levels of the WHO regarding the semen analysis. And what's about hypogonadism? About 38% of men over the age of 45 are suffering from
खुद ही हो गया मैंने तो
hypogonadism.
नहीं किया
And before 40, 7% are suffering from
ये हुआ
hypogonadism.
कैसे है मेरा तो हाथ भी नहीं धोता
The other onset of hypogonadism is associated with low testosterone, low energy, low libido, decreased lean body mass, depression,
इधर बड़ा
and
शीशा आ रहा है
But we have permanent
ब्लू फेंडर में भी शीशा है इधर भी शीशा
uterine
है
dysfunction, which caused by congenital like the Kalman syndrome and the local tissue destruction from pituitary tumor or surgery or
क्या
radiation.
करूँ उसने फिर
There is a temporary decrease in the pituitary function only with the use of the exogenous androgen, which suppress the pituitary release of FSH and LH.
अब देखो
Male infertility due to hypogonadism, result from deficient secretion of LH and FSH. And this will lead
ਚਮੱਕੇ ਮਾਰ
to low
ਤੁਹਾਡੇ ਕੈਮਰੇ में ਮਾਲਕਾਂ ਨੂੰ ਦੱਸਿਆ ਨਾ ਜਿਹੜੇ ਤੁਹਾਡੇ ਪਿੱਛੇ ਤੁਹਾਡੇ ਮਾਲਕ ਖਲੋਤੇ
and testicular atrophy. That's
ਜੈਨੂਨ
why
बात वीडियो बना के भेजा
gonadotropin therapy aims to restore
पता नहीं वही चार्जर का मसला है
number one, spermatogenesis
एक
and
दूसरा
to
नहीं
normalize androgen level. This is the review of the physiology regarding the role of LH, FSH, HCG. What are the indications for gonadotropin therapy in males? Number one, congenital or acquired hypogonadotropic hypogonadism. Number two, post-anabolic steroid use. Number three, functional hypogonadotropic hypogonadism. Let us start by the use of HCG, gonadotropin, in male infertility. The mechanism, the HCG mimics the LH. That's to say, it will stimulate the Leydig cells, leading to increased production of testosterone. This will restore the intra-testicular testosterone concentration, which is essential for spermatogenesis. The clinical use should be the first line in secondary hypogonadism and often started alone initially for several months to restore testosterone and induce testicular growth. The typical dose is 1,500 to 2,500 international unit subcutaneously or intramuscular 2 to 3 times weekly. The response, testicular volume increase within 3 to 6 months. If the sperm don't appear in the ejaculate after 6 to 9 months, we should add FSH or HEG. The outcome, men can successfully regain spermatogenesis and fertility, and it's important to note that it can take up to 2 years. But can we expect the outcome? Yes. If we have a larger baseline testicular size, post-pubertal onset of hypogonadotropic hypogonadism, or low body mass index, these are predictable prognostic factors for the outcome. We should keep in mind the side effect. The side effect, mostly no adverse side effect, and we should know what are contraindication, hypersensitivity to human gonadotropin, known or suspected sex hormone dependent tumors, precocious puberty, and we should be cautious since androgen may cause fluid retention. And HCG should be used with caution in patients with cardiac or renal disease. The second is the human menopausal gonadotropin and the recombinant FSH. What is the mechanism of action? HMG contains, as you know, FSH and LH. For pure FSH, this will stimulate Sertoli cells, and this will remove spermatogenesis. What's the indication? As we mentioned, after HCG therapy, if spermatogenesis fails to initiate, we should add FSH
ਭਾਈ ਨੂੰ ਸਹੀ
or
ਗੱਲ ਕਰ ਰਹੇ ਸੀ,
HCG.
ਤੁਹਾਨੂੰ ਮਨਾਉਣਾ ਤੇ
See,
ਊਂਟ ਨੂੰ ਬਾਣਾ ਕੀ ਗੱਲ ਹੈ।
HCG is certified international unit. FSH
सीखा करो सीनियर से सीखा करो, आपके उस्ताद हैं,
2 to 3 times a week.
आपके उस्ताद
The duration
आपके उस्ताद हैं।
is long term, just to say 6 to 8
मैं हूँ ਇਹਨਾਂ ਨੂੰ
months
ਈਵੈਂਟ ਤੋਂ ਚੱਲੇ
is to achieve sperm ejaculation.
ਅੱਜ ਮੈਂ ਈਵੈਂਟ ਤੋਂ ਬਾਅਦ ਖਿਲਾ ਲੈਣਾ, ਤੁਹਾਡੀ ਬਾਤ ਨਹੀਂ ਨਿਕਲਣੀ।
With different types of gonadotropin.
ਤੁਸੀਂ ਫਿਰ ਕਹਿਣਾ ਉਸਤਾਦ ਜੀ ਉਸਤਾਦ ਜੀ,
The HCG, the HMG, and the
ਬੇਸ਼ਰਮ
FSH.
ਸ਼ਾਗਿਰਦ ਇਹੋ ਜਿਹੇ ਹੀ ਹੁੰਦੇ ਨੇ ਅੱਜ ਦੇ ਦੌਰ ਤੇ।
The treatment protocol will repeat again.
उस्ताद उस्ताद ही होता है, अक्ल किया करो।
Estimate FSH, LH,
सारा उन्होंने आपको सिखाया है,
and FSH and LH.
मैं तो सीखता रहता हूँ, तो मानता हूँ, लेकिन आप मानो कि वो आपके उस्ताद हैं।
is HCG.
स्विचिंग उन्होंने सिखाई, लाइव उन्होंने सिखाया आपको,
No
ओबी का
spermatogenesis
सारा
after 6 months.
ओबी का भी उन्होंने बताया।
The
ਮੈਨੂੰ
next
ਸਿਰਫ
step.
ਹੋਣ ਦਾ ਪਤਾ ਹੁੰਦਾ ਸੀ।
And the next step
ਆਸਾਨ
is
ਫਰਾਮੋਸ਼
to add
ਸ਼ਾਗਿਰਦ ਹੋ ਤੁਸੀਂ।
HCG, and we should monitor the semen analysis every 2 to 3 months, and the duration 6 to 8 months, as you mentioned. We should evaluate the response regarding the volume of the testicle, which should be
मौलवी साहब ਤੁਹਾਡੀ ਨਜ਼ਰ ਬਹੁਤ
the
ਤੇਜ਼ ਹੈ।
appearance of the sperm and the pregnancy rate in this condition about 50%.
मैंने ये भी कहा सीखा करो।
This is an algorithm for treatment of male factor infertility. If we, as we mentioned, and low testosterone, and to go as we mentioned. But in consideration, the other scenario.
हड्ड हड्ड राम बन
Organism, and the treatment varies HCG, and the failure we should add FSH and HMG.
स्विचिंग वाला
This is primary testicular failure, and no effective hormonal therapy.
वो तो मैं खींच के रखता हूँ,
The other scenario, if
पता
we
नहीं कहाँ
have
करके खाते हो।
normal FSH, LH,
ਤੁਸੀਂ ਤੇ ਕਹਿੰਦੇ ਅੱਲਾ ਕਰੇ
or functional suppression,
जी,
and the treatment in this condition, trial HCG will fix great. The last possibility is normal hormones and normal
काम
semen.
अच्छा करते हैं अगर इनका
Hormonal management, exit or IVR. So to come to the key laws, don't
Any-
use exogenous steroid, it will suppress the
नहीं बुलाते।
conception 50%. Predictors of good response, larger baseline testicular size,
कैसर भाई उनसे मेरा कार्ड ले
may
Yeah, man,
factor infertility.
ये चल जाएगा फ्रेम, तीनों फ्लैग से आ गए।
Guest of honor for today. May I request you, sir, to please
सिंगल
come
कैमरे के
for
पैसे
closing
में देखना
remarks.
आपने, देखना सीधा। किसका फोकस कर लो ना।
Well, the remarks that I intend to make are that I want to congratulate Mrs. Krishna for organizing this ceremony. And
यार ये काला ट्राइपॉड बहुत ज़्यादा प्ले दे रहा है।
with gratitude to Professor Elnashar
कैसर साहब वाला
for coming here all the way. And
तो भैया आप उम्र आपको बताने बहुत ज़्यादा प्ले दे रहा है, खड़ा ही नहीं होता ये काला वाला।
area that he has conveyed to us. Gratitude to all the speakers who have been here, and of course, cannot be without all of you sitting here as a body of gynecologists here to avail the opportunity to be more educated, learned, and whatnot. I think this will go as a means. This activity will be the means.
SMD के बनाओगे ना पिक्चर ज़्यादा जान में आएगी, उधर से जाके थोड़ी क्रॉस स्क्रीन में आए, आपकी खाली वो पीछे वाली फ्लैग से आएंगी ना, पिक्चर की जान बढ़ जाएगी। मेरा ख्याल है, गलत भी हो सकता है।
Thank you very much, sir. And now we are done with the scientific program of today. आप सब के आने का बहुत शुक्रिया. Special thanks to Professor Elnashar for all the way coming here and enlightening us with the very useful
Sir.
and informative lectures. And thank you very much for all the speakers. आप सब के आने का बहुत शुक्रिया. लंच लेट हो गया लेकिन कोई नहीं, प्रोसेस था लर्निंग का. Let's proceed for the lunch. Thank you.
कट कर रहा हूँ भाई, आसिम भाई कट कर दूँ।